So hopefully the exam went well. I'm sorry that we can't be meeting in person for the rest of the semester. Um, but I'll try to give you as many mom looks as I can from this video. The format will be me giving some lectures like I would in class with drawing on this dry eraser board here instead of in class. Um, and then there'll be a break for some kind of assessment or practice sheet like we would normally do. And then there'll be the next video. And so each time we have class, I'll give you the schedule so you know what to do next. Um, in terms of reminders, next class, at the beginning of class, there will be the quiz, and that quiz is going to be on the autonomic nervous system. And it'll be much like the exam in which you have to do your check-in, and then you can get the password for the quiz if you finish the first neuro ATI. Other assignment is that discussion board that I didn't open before my trip. So you'll have to go under week 8's content in order to do the discussion board. And the due dates will be listed there like usual. So where we left off was the lower respiratory medications. And we start with allergies that might affect the lower passages. So we talked about using antihistamines and topical anti-inflammatories like fluticasone for upper respiratory allergic rhinitis. You can get allergic rhinitis with postnasal drip that causes coughing, or you can get, more allergy symptoms in the throat and upper bronchus. And so the first medication that you can use, which is listed under asthma, which is also sometimes used for exercise-induced asthma, which is why it's there, is cromolyn, which is something called a mast cell stabilizer. So last class we talked about how the allergic response occurs because the mast cell gets sensitized by antibodies, IgE specifically, and those antibodies are sensitive to allergens. So instead of what it's supposed to be, which is an antibody attaching to an antigen and alerting the immune system to an infection, for some reason the body has decided to get triggered by an allergen in the air. So when the body's exposed to that allergen, the mast cell opens and releases histamine and leukotrienes, which is what causes the inflammation and mucus production and itchiness and all those symptoms that people feel. So you can use antihistamines to try to decrease those symptoms. The other thing you can do is an inhaled medication called cromolyn, which suppresses inflammation by blocking the release of these that come out of the mast cells. So that's why it's called a mast cell stabilizer. So even though you're exposed to the allergen, if I stabilize the mast cell, then it can't dump histamine and leukotrienes, and I won't have the symptoms. So you're supposed to use it pre-exposure, or you could use it 15 to 30 minutes prior to exercise. It's not a rescue medication. It won't help you in terms of an acute allergic attack or an acute asthma attack. And because it's just topical treatment, there's no systemic side effects. It's the dry mouth, headache, and aftertaste from the inhaler itself. Now, in order to understand the inhalers and the stepwise way that we treat asthma, we have to go over what asthma is. And part of it is the allergic response. People with asthma tend to be hyperallergic to all kinds of things. They'll have what are called triggers, which most asthmatics should be monitoring, such as common allergens like dust and cat dander and environmental allergies. Other triggers could be cold weather, getting some kind of infection, cigarette smoke, stuff like that. So asthmatics should always kind of monitor what those triggers are, and a lot of those triggers will cause the histamine and leukotriene release, just like normal allergies. People with asthma also have cough and spontaneous bronchoconstriction, where that breathing tube gets really small, so they feel like they can't get air. And then because of the allergy response, they'll get mucus production inflammation. And over time, they'll get something that's called airway remodeling, which means continued inflammation to the airway causes the airway to scar. So treating asthma is done in a stepwise approach because not everyone's asthma is the same. Some people have very mild asthma, it's only exercise induced. Some people have asthma where they have maybe one event attack a month or twice a month. And as long as they avoid their triggers, they're basically okay. And some people are having asthma attacks weekly or every day. So the treatment is different depending on what the patient's symptoms are. So the first line treatment for people that have this cough bronchospasm or exercise-induced asthma is albuterol. And albuterol is the only rescue medication, which is important to remember for any pending exams, and it lasts for 2 to 6 hours, and you can only use it up to 12 times a day. So, in order to remember or think about what asthma does, what albuterol does, you have to remember the effects of the sympathetic nervous system, and that is, what are the receptors on the lungs? Hopefully, if we were in class, I would ask the whole class and look at you sadly if you didn't know the answer, because the receptors on lungs are the beta receptors. And in response to sympathetic stimulation, the lung tubes will dilate, get bigger, so that you can get more air in. And that's what albuterol does. It acts like epinephrine, norepinephrine on those lung tubes in order to open up the airways to get rid of the spasm and cough symptom. So in order to also study for this exam, you need to review the proper way to give inhaled medication. So you only prime it the first time you open the container, you shake it up really good, you take a deep breath in and out, put your mouth around the inhaler, and as you're breathing in, depress the canister, try to hold your breath as long as possible, although during an asthma attack that will be hard. It's hopefully for 10 seconds, but probably not. And then remove the inhaler and blow out at the same time. And you're not supposed to do another medication for 30 seconds to 2 minutes. You're supposed to give yourself a chance to let that deposit into your airways. And then you can do it a second time, the same as the first, and switch your mouth out because there's a bad aftertaste. If you're using it for exercise, then you should do it before exercise. So because, unfortunately, there will be some systemic stimulation or absorption because the airways are actually where you can deliver medicine. So say you were in a situation of shock and you can't get IV access, you can actually give rescue drugs down a breathing tube. It does absorb systemically. So the person can expect certain side effects like headache, potentially tremor, tachycardia, throat irritation. Those are the main ones. So you should inform the patient, especially about the tremors and the palpitations, because that's almost certainly going to be an issue. And then you'd have to worry potentially about dysrhythmias if their heart rate gets too fast. And for some people, they can have a paradoxical bronchoconstriction, and that is one reason how these medications can increase the release of asthma-related death. But that's not very common, and that's more common with the long-acting beta agonists. So key things to remember about albuterol is how it works. It's acting like the sympathetic nervous system on the beta receptors in the lungs, opening up the lungs. It's the only rescue medication. It's one of the medications you can use for exercise-induced asthma besides cromolyn. You're going to have some systemic side effects that the patient needs to be warned about so they're aware of it. And got to be sure the patient gives the medication correctly and doesn't take it too often because it can develop a tolerance. An alternative to albuterol is what's called atrovent or ipratropium or tiotropium, which is Spiriva, which is used in COPD, because it will, over the long term, try to keep the lung tubes open, but its mechanism of action is different. It works by blocking the parasympathetic nervous system response. So we will talk about after lunch more information about what the parasympathetic and sympathetic responses are. But this medication is considered an anticholinergic, so it's blocking cholinergic receptors, blocking parasympathetic nervous system receptors. And so the parasympathetic nervous system is our change in priorities. It's not fight or flight, it's rest and digest. And so we don't need to take extra oxygen in, so there's no increased bronchodilation. So if we block that response, then bronchodilation can occur. With less of the issues that people get, like the tremors, tachycardia, irritability, anxiety, just mostly dry mouth, bad aftertaste, throat irritation. You do have to use with caution and glaucoma and urinary retention, and we'll explain more of that after lunch. So that is one option. The other option, so usually you start with asthma by trying to use rescue inhalers and avoid triggers. If the person is having too many symptoms, then the next step is inhaled corticosteroids. And our prototype medication is beclomethasone. The brand name of that is QVAR, but there's many, many types of inhaled corticosteroids. And what you're trying to do is decrease the inflammation. So the albuterol gets rid of the cough spasm when it's occurring. This is supposed to work over the long term by decreasing inflammation in the lung tubes. So it's easier to breathe. So there is a possibility of systemic absorption, but not as bad as if it were oral. And so then you have to remember corticosteroids are in the same family as prednisone and hydrocortisone, which we've talked about on multiple occasions. The main side effects that a person has to be aware of is hoarseness, dry mouth, cough, sore throat, and it can lead to a fungal infection in the mouth. So the patient has to be very careful about rinsing their mouth afterwards. So people usually rinse their mouth after albuterol just because it's a bad taste, but you have to rinse your mouth after inhaled corticosteroids because you could get a thrush or candida infection in your mouth. Which, as in class, I would say, what are the symptoms of a thrush infection in your mouth? And you would say, brightly back to me, like you always do. Altered taste, weird sensation on the tongue, or those adherent white plaques or pieces on the tongue. Sometimes a patient will be prescribed albuterol and beclomethasone as a treatment regimen twice a day. And if that was the case, then they should always do the albuterol first. That's a key point. Put stars around it. Because you want to open up the lung tubes so that they get the most out of the inhaled corticosteroid. So you always give albuterol first. The other thing that you want to put stars around is when you're giving two inhaled medications, do the one with the two, like we said, with the waiting 30 seconds to 2 minutes between each puff. And then you have to wait 2 to 5 minutes before you do the next medication. So there is a larger block of time in between the first medication and the second medication, which may also be on the exam. The last medication in this group, so say the patient is on an inhaled bronchodilator, they're on an inhaled anti-inflammatory medication, corticosteroid. The asthmatic probably will be on antihistamines because there's usually a trigger that involves an allergy. And they might still have symptoms, so the next step would be to add what's called a Leukotriene Modifier. And these block the effects of leukotriene and are very good at stopping inflammation as well as trying to alter the airway remodeling. So it's a really good medication for people with bad asthma. So this blocks the leukotriene receptors, reduces inflammation, but does not cause bronchodilation. So this is not a rescue medication. It's only to decrease the symptoms of asthma. Some issues with that are headache, cough, GI upset. For elderly, it can increase risk of infection. There is an issue with possible liver dysfunction. However, it's more of an issue with other medications in this class than what is montelukast or Singulair, but we still bring it up as a possibility. So then that could be your next step. Sometimes people will be on, they'll be avoiding allergy triggers, they'll be on an antihistamine, they'll use bronchodilators as needed, they'll be on a long-acting bronchodilator that might be mixed with an anti-inflammatory like Advair. They might add Singulair, and if they still have bad symptoms, they might actually be started on a biologic medication, but we're not going to talk about that for this exam. So, if you've gotten to this point in the class, you've taken the exam, you could have asked any question about the exam on the discussion board, you watched this video, and then there is a non-graded matching test that you're supposed to take after watching this video that will ask you questions about all the respiratory medications, both upper and lower respiratory, and have you match them to the mechanism of action. And after you've finished all that, it's probably a good idea to take a break, and then we'll start talking about the nervous system and how those medications work.